So I'm Patrick Washington Serruys. I'm established professor of interventional medicine and innovation in Galway. And I'm a consultant of the Advanced Center for Imaging and the Corey Lab. I think that by saying symptomatic, you reduce the landscape. Because I think, we have published last year the textbook on aortic valve, on TAVR, with the late Alain Cribier and John Webb, Rashmakar, Leonard Chelinov, usual suspect. And then in that book, there is a big chapter on prevention of aortic stenosis. So there are now 4 or 5 drugs who can slow down the calcification of the valve. So I have to mention that. Then you have the big block of symptomatic. And then what is the field moving to is the asymptomatic. This morning we had a beautiful lectures and LBT from Philippe Généreux at PCR. And it's all about asymptomatic patient. But about the symptomatic, you could say that we are moving to what we call the moderate aortic stenosis. So it's a little bit technical, but if you have a velocity of the jet above 4 and 40 millimeters of mercury, you are severe. But if you are between 3.1 and 3.9, then you are moderate. The problem of the moderate is that it's a mixed bag. Its patients are moderate but going to the severe, but there is also moderate will remain moderate because they low flow, low gradient because of fibrosis. It's already too late. But that's a big field, the asymptomatic, the symptomatic, and some prevention that will come. Yeah, I mean, you have to go back to 2019. You have 2 giants, Edwards and Medtronic. There are other people coming, but basically they are the 2 golden standards. So I've been working with the Indian people since the year 2000 on stent and many other things, a slow process. But at some point they had a good domestic product and how to introduce that in the world, So what we did, we said we are going to compare their valve called Myval versus the golden standard, that means versus the Medtronic Evolut and versus the Sapien Edwards. The point which was difficult is that everybody make iteration in the valve. So we said, okay, we'll took everything. Whatever comes as a new iteration will be in the so-called contemporary group, the 2 golden standard. So it's a randomized trial between these 2 groups. So first, we take severe aortic stenosis, symptomatic. Yeah, that's point number 1. Point number 2, the decision to treat the patient is basically the decision of the heart team. That's something new, because we don't have really inclusion-exclusion criteria. What we have is, according to the ESC guideline of 2021, finally is the heart team who say, I want to do something for this patient. That's point number 1. Then we randomize Myval versus the contemporary group, which is a combination of Sapien and Evolut of Medtronic. And then there are 2 phases in this trial, and we have to talk about the 2 phases, because everything is done according to the VARC-3. VARC-3 is the Bible of the cardiologist. Now, if you are a trialist and an investigator, you follow the recommendation of VARC-3. And VARC-3 said, at 30 days, we look to the safety and the efficacy, but the safety. So there is 7 components there, of course, death, of course, stroke, but then bleeding, kidney failure, damage of the vasculature, pacemaker, conduction disturbance, all kind of things acute relate to the safety. And that's it, 30 days. And then VARC advised at 1 year something different. You still look at death and stroke, But then you look at rehospitalization, and the reasons for rehospitalization are huge. It could be some structural deterioration of the valve, some hemodynamic deterioration of the valve, or complete failure of the valve. You have to replace, yeah? So that's the two phases. The first phase, we achieve non-inferiority versus the two others. Then we make a little bit the detail in a publication, Euro-Intervention, on specifically Myval Evolut, Myval Sapien, quite instructive. And then in the things that I have presented this morning, the outline of this morning was about the 1 year. And again, we see that there is non-inferiority a little bit on everything. So if you look at the number of deaths, for instance, the ultimate criteria, 27, you cannot argue with that. You don't need statistic. If you look at the stroke, okay, 21-13, but not significant. If you look at rehospitalization, 16-20, not significant, and sometimes going in different direction. So if you combine these three date events, because there are date events, there is a date for the death, there is a date for a stroke, there is a date for rehospitalization, completely neutral. Freedom is around 89% in both groups, yeah. It's a difficult question. I think the big novelty of that technology from India is what we call the intermediate nominal size. They are the first one. If you take Edwards, you have jump of 3 millimeters between the nominal size. So 20, 23, 26, 29. If you take the Medtronic, it's also jump of 3 millimeters, but then suddenly 5 millimeters between the 29 and the 34. And people forgot that the surgeon have also jump of not 3 millimeters, but 2.5. So he has a jump of 1.5. So when you come in the lab and you see the valve, the multi-slice CT scan, and they tell you the diameter is 21.5, if you work with the conventional valves, you have to take either 20, underestimate, or 23, overestimate. And then there is always the risk of ruptures and all these things. So that's the novelty. But today, to be completely honest, we have not yet extract in a significant way the value of that. We have trend because the number of in the study is not major. Maybe I did not mention 768, 384 in each group. So it's still small numbers. Okay, it's good for a composite endpoint, but not for that kind of subtlety. We have created a fitting index because basically if you need the shoes 20, 21.5 or 23, you need to have the right nominal size. So the fitting index has been created, and we will explore with the other trial, Compare TAVI, which has been done in Denmark. We're going to pool the patient and see if really this possibility, the spectrum of size has a clinical impact on pacemaker, on regurgitation. That will be important. Now, one thing you should not underestimate, it's a little bit tricky to talk about that, is the clinical cost benefit. Okay? I mean, obviously, technology coming from the United States was expensive. Medtronic was always mitigating the price somewhat. Okay, that explained that some of the people have been attracted by the self-expanding. And then suddenly you have an outsider, which is India. They have changed in 3 years. They have made 3 iterations. So India is teaching and producing 10 million engineers per year. Per year, okay? So you see valve very stable over the years of moving the iteration as slow. This guy in 3 years, bang, 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 they changed drastically. you know, from an hexagon to an octagon. Very amazing. So I think that it's already there in 82 countries in the world. And I think that the simplicity is now a very short valve, 18, 21 millimeter. The shortening is really minimum, 12%. So it's maybe a valve for Mr. Everybody, you know. You don't need to be a prima donna in Tavere to do these things, you know. What I've learned in trial that I did in the previous decade, that the 10 years follow-up is essential. It's only after 10 years that you really get the answer. Curve can diverge and converge. Curve can diverge forever. That's a serious signal. But when they diverge and converge, there is a moment of vulnerability and then it disappears. That's point number one. Point number two, long-term follow-up is important. And then the issue is to go to do what we call preemptive treatment. You don't wait for the damage of the myocardium. You treat the patient. He has the disease, he has the gradient, but not yet the damage. That's the moment to do something. Because when the damage is there, it's irreversible. It's fibrotic, it's nothing to do. So that's, I think, we are going to go in the direction of preventive treatment, preemptive and preventive treatment, both. That's what is going to happen, yeah.